Hi there. Wonderful to have you here. Leslin has been doing our meet and greets with our event people. Oh, I
Uh-huh.
just noticed it says sponsors, but this is meet and greet with one of our speakers, one of our presenters from our conference coming up, our heart to heart virtual conference on keto and beyond. And one of the questions that we have gotten again and again and again has to do with the semaglutides. Now, if you're not sure about the semaglutides are the Ozempic, Wegovy, Manjaro, Zepbound. I think I'm getting the major ones
Yes.
that are out there. And so we have invited Dr. Matthew Carmody. Hi, Dr. Carmody. Dr. Carmody is an internist. He's also a diplomat in obesity medicine. And I remember talking to him when um, when the thing with the semaglutides came out, and he was so excited about them. And he is going to be speaking at the conference on the April 14th. But welcome, Dr. Carmody.
Thank you. It's good to be here.
And I forgot to say he's also on the faculty at Harvard Medical School. So semaglutides, what are they? How do they work? Why? I mean, so many of our ladies are asking the questions about if it can work with lipedema. Let's not start there. Let's start with what are they?
Okay. So they are medications that have been fashioned after hormones that the body uses. So your body is using something that is like semaglutide. Um, and semaglutide in the body is found actually in the gut, and it is positioned in a way that it monitors what is coming down your gut. So whatever you have eaten is passing by a monitoring system to determine, for the body to determine what you've eaten. And what this monitoring system does is it actually gives information to the brain and to other organs about the fact that this is what you've eaten and this is what we want to give you to allow you to digest well or to digest appropriately. So semaglutide is actually fashioned after one of these signals, one of these hormones, so that it's not the hormone itself, but it's part of the hormone. And so it has been fashioned to be given by oral route or subcutaneous route. And it's found that the subcutaneous route works best. So, what does this do? So, semaglutide actually goes to the stomach and actually slows the stomach's emptying. And what that does for you as a human being is it makes you feel filled because your stomach empties more slowly. It goes to your brain and to various parts of your brain, not just one part of your brain, and sends a signal to that part of the brain, or develops a signal that says, I am satisfied. I do not need to eat more. So the two signals that semaglutide mounts are the signal to the stomach, I am full. And it actually prevents the stomach from emptying. It slows the emptying down, and it goes to your brain and actually sets up an attitude in you that basically says, I am satisfied. I do not need to eat. And it is based upon those two effects primarily. There are other effects, but those are the primary effects that allow you to say, I don't really need to eat here. I don't have the desire to eat. And in addition to that, I feel full. I don't have a hole in my stomach. I feel very comfortable. Now, these have been used and studied very extensively in people with obesity. We know that people with lipedema is a category of obesity. It seems to be different from other categories of obesity in terms of what the problem is. And lipedema can be distinguished from obesity. But in terms of who has obesity, does anybody have lipedema and obesity together? And the answer is yes. In fact, only 40% of people that have lipedema alone, just by itself. And the other 60% have some other trouble. Most of the time, it's obesity. So as semaglutide has been developed and tested, I can tell you the medical community, when it tests people, does not distinguish well between people with lipedema that have obese appearance and people with obesity that have a slightly different appearance. They do not distinguish between those two, so that the community of lipedema to the research community is very much like the community of obesity. So that inadvertently, as it were, without proof, lipedema patients, in fact, have been studied with semaglutide. It's just that people didn't know that they also had lipedema because they're unable to diagnose it. In fact, the clear diagnosis of lipedema has escaped us for many decades. Mm-hmm. And recently, there will be a publication that will be available to you in the scientific literature that in fact gives you a way to distinguish lipedema from obesity. So you're in the position, semaglutide has been used on people like you if you're a person with lipedema, and if you're a person with lipedema and obesity, and a person with obesity alone, all of those patients have been studied or have been included in studies of semaglutide. The second thing that we know that's really important is with any kind of intervention in obesity and even in lipedema, there are people in which it works spectacularly and they have no side effects. There are people that it works pretty well, like gives them a 50% response, and they have no side effects. And there are people with lipedema, I presume, that it's been tried in, that it has also worked. But we know that in any of those people, any of those groups, there are people in each group that for reasons unclear to us, even in all interventions in obesity, some in that group respond superbly. Some are moderate responders and some respond not at all. Some people have no side effects. Some people have some side effects. Some people have a lot of side effects. A lot of side effects means that you will probably need to discontinue the medication. So the answer to your question is semaglutide is actually a hormone, GLP-1 antagonist or a stimulator that actually is very important in everybody's controlling their weight. That it's already in you, it's already working. And semaglutide is a molecule that's like GLP-1 that actually is also given in larger amounts to attempt to create the environment of GLP-1. Semaglutide is trying to enhance that environment. So the environment is, I'm full and I'm not mentally hungry. I don't want anything. Mm-hmm. So there's the short answer.
And we're going to have a much longer answer to this at the upcoming event. Our event is the April 12th, 13th, and 14th. And if here it is, Heart to Heart Virtual 3-Day Event Conference, Keto and Beyond, Customizing Your Plan to Joyful Nutrition. And there's the link, and Gail will put the link in the chat as well. If you haven't registered, do so and join us. You know, Dr. Carmody, all right, so here's the deal. You told me about the semaglutides, got to be a couple of years ago. And I'm very medication averse. I don't like to take medication. You know this about me.
Yes.
You were my primary care for years, and it was hard for you to get me to take a Tylenol. And so, and I've tried everything under the sun. So I finally decided to give it a try. And I don't start it for a couple of weeks, but as most of you know, we talk about N=1, where you're your own laboratory. So I'm going to start in a couple of weeks after the conference, actually, because I'm going to go see my current primary care and work with her on all this. What advice would you give someone, maybe someone like me who's tried everything under the sun and has had great success in different time periods, when I was weighing and measuring my food, when I was doing a 12-step program, until lipedema hit. When lipedema hit, all bets were off. Then I got sick, and then I had central lymphatic dysfunction. So I'm dealing with complex issues. What advice would you give someone like me? Not me per se, but someone like me.
I guess that I would go back to one point that I just made a little bit ago, is that for any intervention, there are people that will respond.
Mm-hmm.
That in a small way. There will be people that respond in a moderate way, and there will be people that respond in a wonderfully robust way. And you cannot, no one has actually found a way to predict that response.
Mm-hmm.
One of the side effects, of semaglutide is it causes a retention, too much retention of fluids or food in the stomach. And so that's something that happens that's usually avoided by starting at a very low dose of semaglutide and then building the dose up.
Mm-hmm.
Because some people are responding on a very low dose, 0.5 milligrams, but most respond to 2.4 milligrams, which is very much above. But most people are starting at a lower dose,
Mm-hmm.
and then they're building to a higher dose. And so that side effect of I retain too much in my stomach, it acts too strongly on my stomach, is avoided by actually having a smaller dose tried, and then advancing the dose to the place where above which it's uncomfortable for you, but at which it is fine.
Mm-hmm.
So that I would think that to answer your question, I can't predict. I don't think that there's any ideal person that's been identified, or a way to actually know by any kind of medications and so forth, or response, or laboratory tests, that you are the person that is perfect. It is only by actually intervening and trying that it becomes possible to know.
Well, we'll see. Yet again, another adventure.
And then whatever your response has been to, stuff, medications in the past, is non-predictive,
Right.
to this. Okay. So there's no medication that this is like, okay, that you could say, if I tolerated this medication, that's perfect, because there I am. I've got it. There's not a medication like that.
Well,
These are unique.
I am very much looking forward to seeing how this all progresses.
Yes.
And we shall see. I guess that's what it comes down to.
Yep.
We shall see. So thank you.
Okay.
And everybody, as long with you, I'm looking forward to Dr. Carmody going into more depth about the semaglutides at our conference coming up. And have a wonderful day.